This is the first Puscast of 2016. Happy New Year, covering the last 2 weeks of December 2015. In case you don't know, my name is Mark Crislip. I'm an infectious disease doc in Portland, Oregon, and I've been doing this podcast now for over a decade. Go me. My growing multimedia empire is over at edgydoc.com, where you will find links to my books and my podcasts and my blogs and my apps. Oh my. Otherwise, I don't have much to tell you. There are no conflicts of interest. I haven't taken anything from a drug rep in 30 years plus. And the references for this podcast are available at edgydoc.com. Otherwise, I think that gets rid of the usual preamble for the year. I'll do it again in 2017. I'll still be yammering away in another year. Let's get on, however, to the literature. Congenital CMV, cytomegalovirus, is not part of my practice, so I don't think about it much. Most of the CMV I see is in transplant or AIDS patients, or at least back in the old days. It turns out that African Americans tend to have more congenital CMV. And this study looked at the epidemiology of CMV seropositivity and found that African Americans had about twice the rate of Caucasian Americans. And interestingly, the real difference was in the childbearing years, which helps explain why African Americans have more congenital CMV disease. But the bigger question unanswered by the study is, why is there more disease in that population than others? So more research needs to be done. I was actually also surprised at the lack of seropositivity in whites at only 42%. I thought everybody was eventually positive for CMV. So for kind of viral-related things, they're not worth a whole long session on. One is that Ebola causes severe rhabdo, and it's a common to get CKs greater than 5,000 with the disease, which might also explain the kidney failure that you see, but rhabdomyolysis seems to be an important part of Ebola virus infections. Chikungunya is coming our way, and there were 3 cases in some Venezuelan adults who developed acute nasal skin necrosis, in association with chikungunya that was a febrile multi-organ system failure-like illness. So although chikungunya usually isn't that bad, some people can get quite sick, and in these 3 patients, they necrosed their nose. I mean, oh, poor guys, that's just awful. Thirdly, double-dose oseltamivir did nothing for influenza compared to standard-dose oseltamivir, except make patients sicker. There are now several studies out to show that increasing the dose of oseltamivir doesn't do anything but makes patients have more nausea and vomiting. And then finally, one of the most appalling things I've ever read, there was a dog imported into the United States. They falsified its rabies vaccination certificate, and the animal came down with rabies. Get this, though. Quote, a shipment of 8 dogs and 27 cats arrived at John F. Kennedy International Airport from Cairo, Egypt. The animals were distributed to several animal rescue groups and 1 permanent adoptive home in New Jersey, Pennsylvania, Maryland, and Virginia. So we have human beings suffering unbelievably in the world, and people are spending time and money for goddamn dogs and cats. I really despair at the human condition. And those dogs and cats is probably from ISIS. It's ISIS rabies, and they're letting them in the United States. That's the reason why they had falsified rabies documentation. Does Trump know about this? I mean, Jesus, we waste all this money on dogs and cats while women, children, and men are dying in horrible conditions. Last week I saw the Frontline show on women escaping ISIS. Maybe they'll take the dogs and cats, but they sure won't take the people. Jesus. Regular listeners of this podcast, and I think the adjective long-suffering would apply, know I keep harping on the fact that infections lead to inflammation. Inflammation is prothrombotic, and when you're prothrombotic, you get vascular events. Another study, this one out of Olmsted County, Minnesota, that showed that when you get zoster, you have an increased risk for stroke. As they say, only a short-term increased risk of stroke. Only? 3 months of increased risk of stroke is not an only for me. And then they say that this, quote, may be preventable with the prevention of herpes zoster. What do you mean may? You don't get zoster associated stroke. And what do you know? We have a vaccine for that. Interestingly, there's some data now to suggest that elderly people may need a VZV booster maybe about 10 years out, although further investigation, of course, needs to be done, and I doubt the insurance companies would pay for a booster at 10 weeks anyway. Another infection that has gone away in part because the VZV vaccine is invasive Group A strep infections. Group A strep loves to take advantage of zoster and chickenpox to cause neck fash. And this study found a 70% reduction in the rate of varicella-associated Group A strep infection since using the VZV vaccine routinely. So if you get the VZV vaccine, you not only do not get chickenpox, and not only do you not get zoster, you don't get Group A strep invasive infections as much. And I would bet you 2 pints of beer at the local pub that it will stop strokes as well. What's the best treatment for chlamydia trachomatis? This study randomized patients to receive doxycycline 100 BID or a single gram of azithromycin. There was 97% cure rate in the azithro group and 100% in the doxycycline group. However, this was in an incarcerated population, so they all had directly observed therapy of their doxycycline and completed a course. One wonders in a real-world scenario where people often do not take their medications as prescribed if doxycycline would be as effective. So I suppose your options are still a gram of azithromycin or put your patient in jail for 7 days and give them doxycycline. Another disease I don't think much of or think about much is chancroid, Haemophilus ducreae. There is a study on the epidemiology of chancroid, and as an STD, it has been decreasing in the world. But interestingly, although everything in this world that's infectious related is interesting, it is now a common cause of a chronic skin ulcer in children in the developing world. So its epidemiology seems to be shifting from STD to chronic ulcerative disease of children's skin. I'll be damned, sometimes you get follow-up from the weirdest places. So a couple years back, we had a case of brucella here. My partner had a patient from Polynesia who liked to slaughter his own pigs for pig roasts. He came down with brucella suis. We thought at the time it was acquired from a pig that he picked up from one of the pig farms. However, there's a study now in emerging infectious diseases of this patient's brucella. And interestingly, although he'd been in Oregon since 2010, the brucella suis he had was related to South Pacific strains, not local strains. So they think the patient got infected 4 years ago while in Tonga. I don't know if I buy it. I mean, the genetics certainly show it, but 4 years of incubation for brucella seems a bit much. He did slaughter a local pig, and we do not know what the strains of brucella are in the local feral populations, although there are evidently no brucella in the commercial populations currently. So, color me skeptical that the patient acquired it 4 years ago and not from his recent pig slaughter. Although I did find one case report of a patient whose last exposure to pigs was 20 years before he had his disseminated brucella suis infection. So maybe. I'll have to call my partner, though, and ask him if the state had let him know this information. As you know, there's a certain glee to be had in finding the source of an infection. There are 3 waterborne outbreaks worth noting in this week's Puscast. The first was in England, where they had a long outbreak of Elizabethingia meningoseptica infections that they traced to the waters in their hospital, and they infected a large number of patients, some of whom died. It went on for 22 months, and 30 patients were affected, and it was in the water supply, and it took them a long time to get it under control. The other one was a outbreak of Legionella that was associated with a hotel fountain. Waterworks are always a nice feature of institutions, and whenever I see one put up in the courtyard of a hospital, I make sure they chlorinate the hell out of it, because the last thing I want is a Legionella production factory in the middle of my hospital grounds or my coffee grounds. And finally, there was an elderly man who kept getting recurrent Ehrmonas infections, and they traced it to his well, or in this case, not so well, water. Ehrmonas, of course, is frequently found in water supplies, and I've been amazed over the years, and I actually ask patients where they get their water from, how many people don't get filtered chlorinated water into their house. And of course, here in the Great Pacific Northwest, it's popular for people to go out into the boonies and fill up jugs with, quote, fresh, clean, unquote, water, complete with animal shit and probably Ehrmonas as well. So ask people, where's your water coming from? You'll be surprised at some of the answers you get. And now that we're past the holiday season, if you happen to see a case of Strep galactolyticus subspecies galactolyticus, ask the patient if they've been exposed to organic turkeys. It turns out that organic turkeys are chock-a-block full of Streptococcus galactolyticus subspecies galactolyticus and could be a potential reservoir for human infections. Personally, I always go with the inorganic turkeys, those made of stone. We opted for goose this year, and if you cook a goose, you end up with a liter, literally a liter of goose fat, and it's wonderful for frying your eggs in. There's all sorts of ways that surgeons like to irrigate wounds: low pressure, medium pressure, high pressure, antibiotics, etc., etc. This is a actual randomized trial where they tried high pressure, medium pressure, and very low pressure irrigation with either soap or saline in patients with fractures. They found that it made no difference what pressure they used, low, medium, or high, but it did make a difference whether or not they used saline versus soap. They actually had more reoperations in the soap group. I was always told as a medical student, way back last century, by my plastic surgery attending, that when it came to wounds, he said, never put in a wound what you wouldn't put in your eye. I think that's reasonable advice. So I usually pack my wounds with soft contact lenses. But low pressure and saline was something I'd rather do in my eye than high pressure and soap. High pressure is also a lot more expensive, so just washing the thing out with a little bit of saline is probably as good as you need to do with a fracture. Now, if you can get your orthopedic surgeons to change, let me know how you did it, because mine have always been a fairly staid bunch when it comes to trying something new. Often when a patient comes in with a serious infection, the patient says they have a beta-lactam allergy, and so much of the time the nature of the allergy is not asked. Often it's something unimportant, like my mom told me never to take it again, or they had a non-urticarial rash. But what happens is that patients get non-beta-lactams as a result. Is that a good thing? Well, it turns out it isn't. This study compared outcomes in patients who received beta-lactams or not based on whether or not they had a beta-lactam allergy. These allergies were of all kinds: rash, hives, anaphylaxis, and unknown reaction. And patients who received a non-beta-lactam for their acute infections, often gram-negative infections, had a worse clinical outcome. They were febrile longer and were also less likely to end up getting appropriate antibiotics for the subsequent infection. But what was the allergic reaction rate? 2.9%. And only the history of anaphylaxis was associated with a higher likelihood of a hypersensitivity reaction. So if someone comes in with a beta-lactam allergy, put allergy in air quotes, if they died from it, then I might be a little hesitant about giving them beta-lactams. But if it's the usual, I had a rash, my mom told me not to take it, I misspelled penicillin on a spelling test, and I've no longer been able to tolerate the antibiotic, well, go ahead and give them the beta-lactam. It's probably safe. Doxycycline has been unavailable at times, and they've certainly jacked up the price because people are using more of it lately, in part because it's a good MRSA therapy. Can you use minocycline instead? Well, there was a review that looked at comparison studies of doxycycline and minocycline and found that it was essentially the same for skin and soft tissue infections, community-acquired pneumonia in otherwise healthy people, mycoplasma pneumoniae, Lyme prophylaxis, and some rickettsial illnesses. Plus, the patient's acne will be cured. So, all good. I don't know, that's it. Only 15 minutes worth. I have all these other studies, but none of them are all that interesting. Aspergillus can be resistant to azoles. Or there was a case of Emoncia, a weird fungal infection, in an AIDS patient in India. Or tuberculosis, or that it was better to treat latent TB in New York City with INH and rifapentine once a week for 3 months. You had better compliance even with directly observed therapy. And turtles are still a big cause of salmonella infections in the United States. Or Cryptococcus can cause a primary laryngitis. Things like that. Kind of interesting, but not even worth talking about. Oh, wait, I just did. I really thought I had more to talk about, but I guess I will bring this to an end. It's New Year's Day, and I have to go downstairs and watch the Twilight Zone marathon. Otherwise, I wish everybody a Happy New Year. Don't forget to go to edudoc.com for links to my growing multimedia empire. And otherwise, thank you as always for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye.